Myself, Dr. Nikhil Kandurwar, I welcome you all on behalf of Maharashtra Ophthalmic Society. We are here for the first round of the contest Teachers of Tomorrow, where different teams from Vidharbha region in this session will be presenting. And we have our esteemed judges from the panel, Dr. Karobi Lahari ma'am from Mumbai, Dr. Sandeep Nagvekar sir from Mumbai, and Dr. Virendra Atnu sir from Solapur. Without wasting a lot of time, I would like to start. The first team who will be presenting is from AIMS Nagpur, and Dr. Meghna will start. So the time restrictions are there for 4-minute presentation. So everyone is requested to stick to their timings, and there are different marks on your the way of presentation. So make sure that you present on the camera so that it will be good for judges to evaluate. So Dr. Meghna, please start.
Can you start, sir?
Yeah. So can I get the timer from Numerotech team?
I never thought my favorite food would teach me concepts later in my life. Good afternoon, one and all. I am Dr. Meghna from AIMS Nagpur. My mentor is Dr. Pooja ma'am. Today I am going to teach you about ophthalmic viscosurgical devices. Now let me tell you a story. During 1970, when there is switch from ICCE to ECCE, this entailed a lot of instrumentation in a small space of anterior chamber. This necessitated the protection of corneal endothelium with substances which are not just transparent, but they spread on the endothelium and also maintain the space in the AC. Then Dr. Endrin was the scientist who introduced sodium hyaluronate as first viscoelastic. For using within the eye, these substances should be non-toxic, they should be sterile, and it should be easy to infuse, easy to remove, and they should be optically clear. They should protect the endothelium as we discussed already. They should retain under positive pressure in the eye. Rheological properties are the specific properties of the substance which defines their nature. Viscosity, it reflects solution's resistance to the flow. As you can see, splashing of water in the jar represents it has low viscosity. And elasticity is ability of the substance to retain to original shape after being deformed. Surface tension is angle formed by OVD on flat surface. Coatability is adhesion capacity of OVD. Surface tension is inversely proportional to coatability. Pseudoplasticity is ability to transfer from gel-like stage to liquid-like stage under shear pressure. Based on these properties, they are differentiated into cohesive and dispersive. Cohesive has high molecular weight and high viscosity, leading to maintenance of three-dimensional structure. As you can see, jelly on the plate. Dispersive, as with respect to honey, it disperses over the surface due to its low viscosity and low molecular weight. The full spectrum of OVDs are divided based from dispersive to cohesive and with viscoadaptives in between. These are the different chemical compositions from high viscosity cohesive to low viscosity dispersives. The different uses during cataract surgery are, it is used in almost all steps of cataract surgery except during hydrodissection and during irrigation and aspiration. It also helps in managing iris prolapse repair, controlling of capillary using. The different uses are these can be used as different techniques like soft shell technique, in which the dispersive, both of them can be used within the same space. Dispersive is used to protect the cornea and cohesive is used to maintain the volume and pressure. Other intraocular surgeries are during glaucoma surgeries and posterior segment surgeries, squint surgeries. Recent uses are viscostaining, viscoanesthesia. Methods of visco removal are bimanual irrigation and aspiration method and coaxial method, in which rock and roll, when there is rock on the IOL, the visco is rolled from the other side, and two compartment technique, in which the visco is removed from two compartments. The complications are post-op increase in IOP and capsular bag syndrome due to accumulation of visco behind the IOL, leading to forward shift shift treatment is NDR laser. Calcific band-shaped keratopathy and crystallization of IOL surfaces are rare. Now let us test the concepts which we have learned. During capsulorhexis, to maintain a deep anterior chamber, the agent to be used is, yes, as you guessed correctly, it is cohesive. During phacoemulsification for coating of the cornea, agent to be used is dispersive. These are the learning objectives of the session. Thank you.
Meghna, your presentation was very nice.
Thank you, ma'am.
And you covered a lot in this short span of time. And only thing is that you mentioned something about doing a YAG laser if there is a trapping of this. So how soon would you do the YAG laser?
Within 1 week post-op, ma'am, like almost 1 week.
And what is a soft shell bridge?
I don't know.
Okay. Sandeep, over to you.
Yeah, I think the presentation was very nice. I mean, she had so much information packed in such a lot of time, and there were very good illustrations. So Meghna, everything was good, but as I always tell, a teacher should be able to inculcate some pearl which every student will take. So I think, what is that one pearl you'd like to give from your topic?
I like to say that cohesives will maintain the space, sir, and dispersives, due to its property, they will protect the endothelium. So, like in whatever steps we are performing, we have to think in such a way. So, for phacoemulsification, we need protection of the cornea. So, we will use dispersive agent. And while doing capsulorhexis, we need anterior chamber deep. So, we use a cohesive agent. So in such a way, like if we know the basic nature and basic rheological property of the substance, we can discuss like their uses.
Yeah, so the main thing the student should know that this is your third hand during surgery. Use an OVD like a surgical tool. When you don't know and you feel that you require a third hand, always the OVD will come to your rescue. This is what the student should take home. Thank you so much.
Thank you, sir.
May I request next candidate, Dr. Samarpita, to start their presentation?
Yes, sir. Can I start now, sir?
Yes, yes.
Good morning to one and all. I am Dr. Samarpita Dhar, and today I am going to explain to you the topic congenital ptosis. My mentor is Dr. Pooja ma'am. Now, what is ptosis? Ptosis is the abnormal drooping of the upper eyelid, as it is divided into two types, congenital and acquired. It is further classified into neurogenic, myogenic, aponeurotic, and mechanical. Here, congenital ptosis comes under myogenic ptosis. In this discussion, we will discuss about the etiology, types, diagnosis, and management of congenital ptosis. Now, before we go further, we must understand how does a normal levator palpebris superioris muscle act. As it is inserted into the superior tarsal plate and the skin of the upper eyelid, its contraction causes the retraction and elevation of the upper eyelid, leading to formation of a lid crease. This is similar to a curtain of a theater. Eyelid, and this is the muscles of pelvis inserting into it. So as the muscle fibers contract, it causes the underlying skin. Now, how does congenital ptosis occur? On one hand, there is a failure of neuronal migration of the muscle, and on the other hand, it is replaced by adipose and fibrous tissue. So there is no muscle. So what will happen is there will be no function of levator. As in this child, you can clearly see he has a very poor or negligible levator function. So it will lead to ptosis. Also, no contraction of levator will lead to no lid crease to be formed, and no relaxation of levator will lead to lid lag or higher ptotic lid on down gaze. So, To classify ptosis, it can be of two types: isolated ptosis, which includes simple congenital ptosis, and non-isolated ptosis includes blepharophimosis syndrome. And when the entire myotome is affected, it will lead to congenital ptosis with superior rectus palsy, in which both superior rectus and LPS are formed from the same myotome. What happens in blepharophimosis syndrome is congenital ptosis is associated with short palpebral aperture with epicanthus inversus as well as telecanthus. And as we have already discussed before, in superior rectus weakness, it will also be hypotropia with congenital ptosis. So what are the other differentials of ptosis? It can be congenital synkinetic, it can be third nerve palsy, or even Horner syndrome. What happens in Marcus-Gunn phenomenon is a branch of mandibular nerve is aberrantly innervating the levator. So what happens is the movement of the jaws in this child will lead to retraction of the ptotic lid. So in congenital Horner syndrome, what happens is a loss of sympathetic supply to orbit. So it leads to the features as described along with pupillary involvement. In congenital third nerve palsy, all the muscles supplied by third nerve will be paralyzed, leading to the features as described. In congenital Horners, there will be meiosis, and in congenital third nerve, there will be bitriasis. And how to grade ptosis? According to the palpebral fissure height, it can be mild, less than 2 mm, moderate, 3 mm, and severe when it is more than 4 mm. Now, how to diagnose this? This we have already discussed before: poor levator function, absent lid crease, and lid lag associated with frontalis overaction. I hope you remember this. Other than that, we need to take a detailed history. Why is visual acuity required? As amblyopia may develop because of long-standing ptosis, compensatory chin lift, and extraocular movement with pupillary examination. Now, how to treat such case? If there is a good levator function, we will perform Fasanella servet as well as levator, but this will not happen here as it is congenital ptosis is primarily myogenic. So severe ptosis will occur with poor levator function, leading to frontalis sling operation. Thank you so much.
Samaprita, that was a very nice presentation. You used a lot of small animations to show the various actions, which was good because it is towards good learning. But I would like to ask you a practical question. Is that if a child with who's 2 years old came to you with a congenital ptosis, how soon would you operate? What would be the factors that you would consider when you would want to do the surgery?
Ma'am, because it is a young child, and first we need to evaluate the grading of ptosis, ma'am. If there is severe ptosis, we need to rule out amblyopia. So before the child develops amblyopia, we must operate on the child, ma'am, because severe ptosis can lead to amblyopia.
Any this about the position of the lid? Like suppose you get a half involvement of the covering, would you still do it, or you would wait, let the patient have a little bit of a head position?
Ma'am, the patient might compensate in form of compensatory chin lift. So we can wait, ma'am, according to me.
Okay.
I think the presentation was good, but there was some technical lag in the video shown by you.
Okay, sir.
So that has to be avoided. Maybe it was because of the poor network connection, but the video didn't run smoothly. So make sure that the video runs smoothly.
Yes, sir.
Yeah, I think it was because of the net connection.
Yeah.
Yes, sir.
Sandeep, any questions from you?
No, no, not really. I
Okay.
think, yeah, it was quite good.
And in a blepharophimosis, how many surgeries would you advocate to the patient? I mean, when you counsel them, would you say that you require one surgery where we will do everything, or you would suggest multiple surgeries for blepharophimosis?
Ma'am, we will suggest multiple surgeries. For ptosis, it will require a frontalis sling operation, and we also need to reconstruct the lid as there is very short palpebral fissure. So that also we need to do, ma'am. Multiple surgeries will be required.
Okay.
So can we move to the next candidate? Dr.
One
Varnika?
second.
Okay, sir.
Yes, sir.
Hello,
Yes, sir.
hello, can you hear me?
Yes,
Yes,
sir. I
yes,
can.
Sandeep.
Yeah, I had one request, Nikhil. Can you tell us whether candidates were on time or not? Because
Yeah,
the judges have
They
noticed.
were on
Yes,
time.
yes,
They
yes.
were on time.
Both were there on time, sir.
So
I'll
if
help.
you can
See the
kindly pass
timer,
that
you know.
message. Yeah, because we
There
can't
is
see
a
the timer.
timer which is seen at the right hand top corner. So if you are
But
joining through laptop, you will be able to see. I think through mobile, it's difficult
yeah,
to see because I
yeah,
have
but if you
joined
can,
2 meetings and one through mobile and one through laptop. So the one through mobile, I can't see the timer, but through laptop, I can see at the right hand top corner.
Sir,
It's very
I'll
simple.
inform at the end of every presentation whether
Yeah,
the time
Nikhil,
is.
you can inform everyone. Yeah, both
Thank
were
you,
on
Nikhil.
time, perfect dot on time.
So, Dr. Parnika, next, can we start?
Good afternoon. Hello, am I audible?
Yes, you are audible. Go ahead.
Yeah. Good afternoon. I'm Dr. Padnika Valat from PDMC Amravati. I'll be presenting on the contraindications of laser refractive surgery. Laser refractive surgeries are done to improve the refractive state of the eye to decrease or eliminate the dependency on contact lenses or glasses. Majority of these procedures are done to change the refractive state of the eye by altering the corneal curvature. To get optimal surgical outcomes in such surgeries, we must choose our patients very carefully, for which we should know the contraindications of these surgeries as well. The various types of laser refractive surgeries, as we all know, are enlisted here. The contraindications can be classified as absolute or relative, depending on the severity.
Parnika,
The
please turn
patients
on
who
your
are,
camera. It has marks.
Mhm.
It has to be just turn off.
We
Turn on.
can't see you.
Yes. Timer has to be stopped. Or we can give her a few more seconds.
I am tracking that.
Yeah.
I think
Other
you can
next
start
candidate, please
again, you
check
know.
your camera beforehand.
hello.
Let's start your video.
Santosh sir, meanwhile, can we take the next candidate?
I think while Parnika gets organized, we can take the next one in this of time, lieu of time.
Okay, Dr. Shreyas Jadhav.
Hello.
Parnika, you're back.
Ma'am, we're actually trying it from our end, but we can't start the video. I
Okay,
don't know. I tried.
you don't get hassled. You do it peacefully. We'll take the next candidate. We'll come back to you after him. Okay, don't get hassled.
Thank you.
Okay, the next person is Shreyas Jadhav, na?
Yes, ma'am.
Yes, ma'am.
Shreyash, are you ready with your presentation? Parnika, stop
Ma'am,
screen share, please.
Yes, ma'am.
Please stop sharing your screen, Parnika. It's at the top end, the red
Yes.
icon. You have to just click on that. Yeah, okay. Who is the next one?
Shreyas Jadhav. Shreyas, start your screen, please.
Hello, ma'am.
Yeah, Parnika, you're ready?
Ma'am, actually, Shreyas and me are in the same
Okay, we can go to the next team.
Okay, you all get organized and we'll come back to you all.
Yes.
Okay.
Dr. Harsha
Yes,
Singh from
yes.
GMC Nagpur.
Yes.
Manish, one
Yes,
case,
sir.
no? Harsha
Hello.
Singh.
Yes.
Uh,
Harsha Singh,
Harsha
Harsha
Singh.
Singh. Yeah.
Harsha Singh.
Hello.
Hello.
Yes, can you hear?
Yeah, we can hear you, Dr. Harsha. Yeah, start sharing the screen.
Started sharing. Can you see
Yes,
hello?
we can see it. Yes.
Is my screen visible?
Visible, visible.
Okay. Okay, so I'll start with my presentation. Good afternoon, everyone. Today we'll be covering the topic of cornea in the headings of anatomy and clinical significance, and we'll be covering the following topics. Starting with embryology, we have the epithelium derived from the surface ectoderm and endothelium derived from neural crest cells. This actually explains why different layers of cornea have different regenerative capacity. Going on to the layers, we have the epithelium, which is basically non-keratinized, shedding at a regular interval of 7 days, consisting of a germinative basal cell layer, followed by a wing cell layer and a flattened epithelial covered by a charged glycocalyx. Together, they're subserving the barrier function. Basal cell layer is actually connected to the basement membrane underneath by hemidesmosomes, and any pathology of the same can actually give rise to recurrent corneal erosions that you see in epithelial basement membrane dystrophy. Also, we are given our immune privilege in the sense that Langerhans cells are concentrated in the periphery, leaving the central cornea clear. Thus, eccentric grafts carry a greater risk of rejection. The maintenance is proposed by the XYZ hypothesis, where XYZ is the proliferation, migration, and desquamation respectively. This gives rise to vortex-like deposition seen in storage disorders. Bowman's membrane is actually any cellular false membrane that does not have the capacity to regenerate, giving rise to scarring that you see in progressive pterygium or extensive PRK. However, like two sides to a coin, we have been utilizing this in anterior stromal puncture in recurrent corneal erosions and recently trying to transplant this layer to remove scarring. Coming on to the stroma, which is the maximum thickness of cornea, is actually avascular owing to the limbal stem cell barrier and compactness of collagen fibrils. However, if this is lost in cases like corneal edema, it can lead to vascularization. These fibrils are arranged in layers that forms the basis of lamellar grafting. And the anteriorly, it's more densely packed, which is why in LASIK, you can get post-op LASIK ectasia, and the same biomechanics has been utilized in collagen cross-linking in keratoconus. These fibrils have a smaller diameter and a smaller distance between them, such that they're not interfering with the path of light. Going on to a very recently discovered layer in 2013 that is offering us more tensile strength than the desmids and has been successfully exploited by Anwar in DAL technique, where depending on cleavage, we have a type 2 bubble between duas and DM, and between stroma and dua, we have a type 1 bubble, which is stronger. Going on to the Descemet's membrane, which is the basal lamella of endothelium consisting of a banded and non-banded portion, ending internally as the Shaw-based line, which is why on gonioscopy you can actually visualize copper in Wilson's disease. It maintains the integrity of eyeball even when the whole stroma is sloughed off. Endothelium, which is basically the most metabolically active polygonal cell layer with an average density of around 3 to 4,000 at birth, going on to less than 2,000 in old age, with an average loss of 0.6% a year and 500 cells per mm square required for adequate function, which is basically to regulate stromal hydration via pump leak process. Covering to the topic of optics, we have, instead of being a perfect sphere, we have a prolate optical system with an anterior radius of curvature of 7.8 and posterior being 6.5 respectively, net refractive power of 45 diopters and index of 1.376. The anterior surface is rather elliptical in shape with the horizontal and vertical diameter being 11.7 and 10.6 respectively. And the posterior surface is circular in shape with an average diameter of 11.7 mm. Any variation from the same can actually lead to megalo and microcornea respectively. Pachymetry is measure of corneal thickness, which goes on from 540 at the center to 670 in the periphery. And in ectatic conditions, it can give rise to a hyperprolate system like in keratoconus. I'll be summarizing it by avascularity of cornea, which is offering it the immune privilege, and angiogenesis would lead to immunogenicity of cornea that needs to be addressed prior to grafting. And the nerve supply, which is basically non-myelinated plexus from trigeminal nerve in form of stromal, subepithelial, and intraepithelial plexus. And any damage to these nerves that can eventually give rise to neurotrophic ulcers. Thank you.
Timing perfect, sir.
Yeah. Your talk was very nice. Okay. And you mentioned all the salient features that is there for mentioning. And only thing is that I'd like to ask you, how will you differentiate a megalocornea from a ophthalmos?
Ma'am, basically the megalocornea, it's just the cornea that's enlarged. However, in ophthalmos, there is enlargement of the entire globe. The intraocular pressure tends to be normal in megalocornea, whereas it's raised in ophthalmos. The corneal edema would be seen in ophthalmos, not in megalocornea.
And any change in the corneal diameters?
Corneal diameter,
There-
ma'am, in megalocornea, the diameter, horizontal diameter is increased like more than 13 in adults or 12 in at birth. In fact, even the corneal endothelial count is lesser in ophthalmos, but it tends to be relatively normal in megalocornea.
And what are the other peripheral corneal degenerations that you know of?
Ma'am, like terrains, marginal degeneration, pellucid marginal degenerations, these are the peripheral.
Good.
Basically, your talk was
Thank
good,
you.
but it uh, appeared like a talk rather than a teaching module. So you should give some touches to your talk in which you are as if you are addressing students, not presenting on a dais. And since we are interacting on a Zoom meeting, your body language also should change when you are presenting it on a stage. I think overall
Yes,
the
sir.
presentation was good.
Can you please stop sharing your screen, Doctor?
Sure.
Yeah.
And you students are looking a little bit tense while presenting. I think they should be slightly freely, they should interact very freely and enjoy whatever they are presenting. I think that will make a huge difference in the presentation skills.
Yes.
Yeah, I think I agree with what Dr. Virendra said. This is not an exam, first of all. Though I would not like to face Karubi at the other end. She seems to be taking my viva. And as I said, basically we are trying to ascertain who's going to be a good teacher. I agree with you, Harsha. You have too much information to give in 4 minutes. But
Yeah.
you have to leave the stage creating an impact, leaving something for the audience and something for the students to take home. I mean, the importance of the Bowman's membrane, the importance of the Desmond's membrane. I mean, those are little pearls you should give so that, students can take something home and learn. Today, knowledge is available for free. You just go on the net, they can get all these things that you're talking about. Okay. Chat GPT will teach you even more. But make sure that your presentation, and this is for all the remaining speakers, you should sound like a teacher, because our topic is not a AIS platform. It's for teachers of tomorrow. So, of course, well done, but you could be even better. Thank you.
Yeah.
I think the previous speaker had something like a quiz at the end of the presentation. She did
Yeah.
not go, but it
Because
was
of
a
the-
good idea.
Yeah, because of the time, she actually just switched off. She could have
Yeah.
taken that slide actually. But
Yeah.
good.
That's a good idea actually.
Yeah, that's a very good idea. Yeah. So I think Dr. Parnika is ready with her video. So-
Sir, we'll finish GMC now.
Okay,
The
okay.
2 minutes.
Shivani.
Yeah, so Dr. Shivani.
नाम change introduce करना बस नाम नहीं आ रहा है change करना Can you see my screen?
Not as yet.
Hello.
Not as yet.
Okay.
Dr. Shivani is using the same laptop. So
Yes, sir.
please consider that. Have you shared your screen, Shivani?
Yes, sir. Please excuse me for a minute. I'm trying.
There's a green button down.
Windows.
You have to keep your presentation open and then press a green button.
Ma'am, can you see my screen?
No, it's black.
Right.
We can
The
see
presentation
you.
screen is to be shared.
Yeah.
Yeah, we can see your screen, but we can't see your presentation.
Yeah.
Okay.
So you do one thing, you just stop sharing, open your presentation, and then reshare. Now you can open your presentation. On the screen, please open your presentation.
So it is open.
If it is open, then you start sharing. And no need to take tension because
Shivani, don't get tense. Don't worry. We are all very patient people.
Okay, ma'am.
we are all students,
Yeah.
obedient
We're
students.
listening to you. Very good. It's come
Yeah.
on.
Can you
Yes.
can you see my screen, ma'am, now?
Yes, yes, yes. Very well.
Okay. So starting with my topic, I'm going to take you through the topic of vitreous substitute via case scenario. A 57-year-old male with PDR has an ambitious idea of going mountaineering 2 weeks later. So, knowing the various pathological changes, possibly this gentleman suffered from tractional retinal detachment secondary to a neovascularization. So, he requires vitrectomy as indicated, followed by its replacement by a substitute, as vitreous cannot regenerate and serves other various purposes. So biochemically, vitreous consists of different types of collagen, hyaluronic acid, chondroitin sulfate cells with metabolic activity. So naturally, when we are looking inert, readily available and economic. So for this gentleman, what are the options? Intra options can be air, which was first used by Dr. O. Balance salt solution as irrigating fluid during vitrectomy maintains IOP, and PFCL used as third end during surgery for unrolling retinal edges. And post-operatively, there are many options like the conventional, newer, and the experimental ones. Coming to intraocular gases, they work on the principle of high surface tension of gas, which helps the bubble opposed to the posterior end of the brake, leading to absorption of fluid into RPE. Apart from this, the expansile property, the gas behaves in a gas from the surrounding fluid enters the bubble in the phase of expansion. Then, in the phase of equilibrium, partial pressure of both the compartments equilibrates. And then comes the phase of bubble dissolution where gas diffuses out from the bubble. Most frequently used are SF6 in non-expansile concentration, that is of 20%, and the C3F8 in 12%. SF6 expands 2 times, whereas C3F8 expands 4 times the volume with a longer duration of action. Silicon oil, difference in specific gravity accounts for buoyancy, which directs the of immiscible silicon oil upwards. It is available as 1000 or 5000 strokes, and removal can be done from 3 months to 30 months. Refractive index of silicon oil is slightly higher than vitreous, leading to myopia or hyperopic refractive shift depending on the lens status. Summarizing, gases have shorter duration of action, requires output based on position, whereas PFCLs are used only for operative purpose because of high specific gravity. Whereas silicon oil, in spite of having longer duration of action, carries a risk of cataract, glaucoma, and keratopathy. Other than single substance, nowadays combinations are also used. Although combinations do have a theoretical advantage of supporting both inferior and superior retina simultaneously, but in practice, they do form an inhomogeneous mixture with minimal dispersion and emulsification. Heavy silicon oils have an advantage of being more viscous, stable, better tolerated, and no significant emulsification. So, with detailed discussion over it, I hope we can help him choose the right vitreous substitutes that is in the form of silicon oil, which has low specific gravity, and the person can go mountaineering with chemically mimic the vitreous and cell culture. We have natural and synthetic polymers, the hydrogels, the transplant implants, and cell culture. So I hope 20 years down the lane, these options can become a reality for patients like vitreous substitutes at drug delivery medium or gene therapy. These are my references. Thanking you.
Timing, okay.
Shivangi, before the boss in retina takes over.
Go ahead. You chided me, so I'm going to keep quiet now.
No.
Not at all.
Not at all. So basically, I think what you should tell your students, and which you can tell us again, in which cases, forget the mountaineering aspect the patient had to go to, which cases will you use gas and when will you use silicone oil? As simple as that.
Sir, in cases where superior breaks are there, we will use the property of gas as it moves up, whereas in inferior retinal breaks, we will use the property of settling down, that is specific gravity. So in that cases, we will use liquids.
Any influence by the kind of retinal detachment the patient has?
Sir, for smaller breaks, we can use liquids. For the bigger breaks, we can use the heavier ones like the PFCLs intraoperatively because it helps unrolling the edges easily.
Karovi, you can take over.
Shivani, do we ever retain the PFCL post-surgery?
No, ma'am. Actually, PFCLs have got a disadvantage of being heavier. So due to pressure effect, it causes the choroid to compress and thus compromising the blood supply of the retina indirectly, leading to ischemic or post-op complications if used for longer duration.
Okay, so you're going to be a teacher of tomorrow, so let me teach you something. See, when you want to tamponade anything which is on top, you can use either oil or air because both rise up. Okay. When you have to do something for the lower part, if there are inferior breaks, what would you use?
Ma'am, the ones with greater specific gravity so that it comes down.
No, see, because everything goes up, you will use a buckle in the lower part. So if you have to combine a surgery where you have to tamponade the inferior breaks, you will use a buckle. And
Yes,
okay, you spoke about mountaineering. So will you leave the choice to the patient, or will you take the choice, this of what you're going to put inside?
No, actually, ma'am, that would be a surgeon's choice, but
So what would be your
to
choice?
present it in a better interactive way, ma'am, my choice would be silicone oil.
Why?
Ma'am, because silicone oil has got ideal properties like that of a vitreous, whereas others has also got, but due to awkward face down positioning or specific high altitude air pressure based complications, like they tend to expand when we move to a less air pressure zone. So liquid won't show that property. So I think that would help.
Very good. So the thing is that it is basically the further expansion which can cause a compression on the optic nerve. That is the reason why either mountaineering or air travel would be contraindicated in the first few weeks when it is there in case of a gas.
Yes.
Thank you. My questions are over.
Shall we move to the next candidate?
Yes.
Shall we go back to Pranali?
Thank you.
Parnika, sorry.
Good afternoon, everybody. Am I audible?
Yeah, you're audible.
Yes.
Go to first slide. Yeah.
Laser refractive surgeries are done to improve the refractive state of the eye and to decrease or eliminate the dependency on glasses or contact lenses. Most of these surgeries change the refractive state of the eye by altering the corneal curvature. To get optimal surgical outcomes, we must choose our patients very cautiously, and for which we should know the contraindications of these surgeries as well. Moving on, the various laser refractive surgeries are as follows. the contraindications are absolute and relative depending on the severity. Patients less they have unstable refraction, so they should not be considered for surgery. And people who are planning to take up the surgery should have a stable refraction in the past 1 year. Any unrealistic expectations of the patient should be ruled out, and he should be counseled properly about the surgical outcomes of the procedure. Any patient who has any kind of emotional instability like depression should not be considered for this surgery. Patients having systemic diseases like diabetes, pregnant women, lactating women should not be considered for surgery, because these diseases do hamper with the corneal hydration and also the refractive state post surgery also. Anybody who's on any kind of medications like amiodarone, somatriptan, isotretinoin, colchicine, levonorgestrel, or any hormonal replacement therapies also should not be taken up, because they cause corneal deposition and eventually hamper with the corneal curvature. Coming to the corneal disorders, please pay a little more attention to this point. Keratoconus is eventually a condition in which there is corneal thinning, so it's an absolute contraindication for the procedure. Corneal dystrophies are also change the corneal curvature eventually, so they are absolutely contraindicated. When a patient has corneal neovascularization within 1 mm of the ablation zone, it can cause interface hemorrhage. Hence, this is absolutely contraindicated. Patients having keratitis, uncontrollable dry eye, or any kind of external ocular diseases like conjunctivitis, leg ophthalmos, etc., are not considered for surgery. However, when patients are patients having an extremely deep or an extremely flat or an extremely steep cornea, are also not taken up for the procedure. And patients having glaucoma, uveitis, or any kind of retinal pathologies like retinal tears and detachments should not be taken up for surgeries. During these laser surgeries, because of the application of suction ring, there's a raise in the intraocular pressure intraoperatively. So glaucoma will even worsen the condition. One-eyed patients are not considered for surgery. And anybody who is planning to join the armed forces, people who are scuba divers or martial arts, they have more flap-based procedures are contraindicated in these patients, as flap dehiscence and eventually globe rupture can occur in such patients. To get better surgical outcomes, we should know the contraindications. Hence, wisely stated by Albert Einstein, we should learn the rules of the game to play better than anybody else. Thank you.
Time okay.
Is on time? Okay.
Yeah.
So I think your name is Parnika, right?
Yeah, Parnika.
Yeah. So Parnika, I'd like to ask you a question as a student. So madam, since you mentioned about pachymetry and keratometry, these are things I want to do, because if I want to do laser tomorrow, I want to know what is your minimum cutoff as far as pachymetry is concerned.
Yes.
I would want to know what is the flattest cornea beyond which I will not do refractive surgery. What is the steepest cornea beyond which I will not do refractive surgery? Can you highlight those,
Yes,
please?
So a patient having a corneal curvature less than 39 diopters there's complete lenticule formation in such patients. And a patient whose corneal curvature is more than 47.5 diopters, they will have a buttonhole lenticule formation. So that's why these extremes of corneal curvatures are not
But
considered for surgery.
these are with regard to microkeratome LASIK. What about femto LASIK surgery? This is not really a contraindication because there's no chance of forming a buttonhole over there. So why is it that beyond 47.5 I would not do? Suppose I'm doing a myopic ablation.
Sorry.
Or what is the thinnest cornea beyond which I will not do keratorefractive surgery? I'm not talking only of LASIK, I'm talking of PRK also. I mean, that is what your students would like to know.
Yes. So less than 39 diopters. Any cornea which is having corneal curvature less than 39 diopters won't be considered for.
Right. Okay.
So pachymetry, when we are doing pachymetry, we'd like to see if the corneal thickness is if it's less than 470 microns, then we won't opt for laser refractive surgeries, because the residual bed thickness will eventually drop down below 250 microns. So we'd want to keep at least a residual bed thickness between 250 to 300, preferably 300 microns for before we want to go ahead with these surgeries.
That influenced by the refractive error. Suppose I have only minus one diopter of myopia and my corneal thickness is 470. Can I do it?
Yes, sir. Because because the refractive error is small, so we can go ahead with the surgery in such a patient. It actually depends on the refractive error the refractive error of the patient preoperatively, and also the corneal thickness. So it's a cumulative effect which is considered before taking up the patient for surgery.
Yes, good.
What about your retinal evaluation? If you do find something in the retina, what would you do then?
Ma'am, a patient, suppose if a patient is a high myope, he's more prone for retinal tears. And if a patient already is having retinal tears or retinal detachments, in such patients, we mostly do not ask them to go for such surgeries, because the post-operative vision will be lesser. And
The question asked is, how will you do a retinal evaluation and what is the significance of retinal evaluation? It's not about the contraindications.
So retinal evaluation will be done
Yes, it will be
to
done.
counsel
But
the
what is,
patient. Sir, if a patient is having any retinal tear, in such patients we initially do a barrage laser, and then we'll go ahead with the laser refractive surgery.
Within how much time? How much time would you give it before you do a procedure for this patient after a argon laser? What is the minimum time that you would give after you have done a laser barrage for doing a refractive surgery?
A month's time.
It would be about minimum 2 weeks. You have to give it 2 weeks time to consolidate. Okay. Yes. Okay. Thank you.
Thank you.
Shall we go on to the next?
Dr. Shreyas Jadhav.
Yeah, let's move on to the next presenter.
Four minutes is supposed to be very short time to present.
That's the teacher's skill, actually.
Yeah.
You know, they should be told not to give extensive talks, you know, and to stick to some few basic points which you want to impart to the patients. Because 4 minutes cannot be an exhaustive time for an exhaustive lecture. I mean, it has to be just the bare points which they should take home.
Someone had joined to do behind.
Can I begin, sir?
Yes, you can.
Good afternoon, everyone. Myself, Dr. Shreyas Jadhav. My topic for today's presentation is optic disc examination in glaucoma. Optic disc examination is the most important marker in glaucoma evaluation. Why? Because 30 to 50% patient have normal intraocular pressure at first visit. Therefore, one cannot absolutely rely on the intraocular pressure, as a lot of patients coming to the OPD have a normal tension glaucoma. 80 to 90% of the ophthalmologists have no access to the perimetry. Even if they have access to the perimetry, it is quite expensive and difficult to interpret. Therefore, optic disc evaluation is the heart of glaucoma evaluation. To begin with evaluation of the optic nerve head, first we will evaluate the disc size. There are total 4 methods. The first method is the gold standard method, which is by the slit lamp biomicroscopy. Second is by stacking of the central retinal vein. Third is by direct ophthalmoscopy. And fourth is by measuring the distance between the optic disc and central part of the retina. Now the size shape of the disc is vertically oval. The margin needs to be sharp. The neuroretinal rim should follow the ISNT rule. The position of the blood vessel should be central. And one also have to take a look at the peripapillary region to detect any abnormality. So optic disc changes in glaucoma. The 5 R that are important in the assessment of the optic disc in glaucoma. The first one is to observe the scleral ring to identify the limits of the optic disc and its size, to identify the size of the rim. Third one is to examine the retinal nerve fiber layer. Fourth is to examine the region of parapapillary atrophy. And the last one is to look for retinal and optic disc hemorrhages. So various type of disc pattern that we can notice in glaucoma. The first one is the focal notching of the disc. Second is the concentric atrophy of the rim. Third is the sclerotic disc. Fourth is the myopic disc. And the last one is the saucerization of the disc. In this image, one can appreciate the focal notching of the disc. What happens in glaucoma that there is ganglion cell loss followed by nerve fiber axon loss, leading to neuroretinal rim loss, which leads to increased cup disc ratio. The vertical cup disc ratio more than the horizontal cup disc ratio. Because of thinning of the neuroretinal ring, focal notching is present, and ISNT rule is not followed in glaucoma. In this image, one can see the laminar dot sign, also known as the slit sign. Visibility of the lamina cribrosa pore is more common in glaucomatous eyes. This is the image of concentric thinning of the rim. What happens in this case is there is large optic disc, large cup. It follows the ISNT rule. The concentric pattern, a loss of the rim, it first starts temporally, then circumferentially towards the pole. This phenomena is also known as temporal unfolding. And if one has to verify that this is because of glaucomatous changes or not, we have to verify it by serial mapping. That is by taking multiple images over the time. This is the third disc pattern, that is the sclerotic disc seen in old ages. The cup is not appreciated much here in this case. Peripapillary atrophy is present and it is associated with the systemic vascular diseases. The fourth disc is the myopic disc seen in young patient. The optic disc is tilted. Temporal crescent of the parapapillary atrophy is seen. This is the saucerization of the disc. There is diffuse shallow cupping extending.
It's not moving.
I think we've lost him.
Yeah.
He was too fast for the internet.
So what is this image? One can see that there is splinter hemorrhage present on margins. So what does it indicate? It indicates hypoperfusion, that is decreased blood flow to the disc seen in normal tension glaucoma.
Again, we lost him.
Think the signal is poor. Keep your video off. Keep your video off and then play.
Last slide is the retinal nerve fiber layer based in the red free light. Because of the, if retinal nerve fiber layer defect is present,
start screen, share your screen.
Yeah, we can see it.
So this is an image of peripapillary atrophy. The presence of beta zone more than the alpha zone is suggestive of glaucoma and its progression. Retinal nerve fiber layer base seen in the red free light. The retinal nerve fiber layer defect indicates early glaucomatous changes. So examination of the optic disc is an important step in the diagnosis of glaucoma and monitoring treatment. Newer modalities like OCT and OCT angiography have made the is clear, but clinical examination remains the first and most vital diagnostic tool in the management of patients with glaucoma. Thank you.
The timing was lost during connection. Otherwise, timing is okay. 10 seconds exceeded.
So Shreyas, if I may ask you a question,
Yes, sir.
can you hear me, Shreyas?
Yes, sir.
So if I were to ask you a question, is that if you were given just one device, okay, to diagnose glaucoma, and it refers to examination, which device would you ask for? You're sitting in front of a slit lamp.
The 90D lens.
Correct. So you basically need to have some stereoscopic examination of the disc. If you just use a direct ophthalmoscope, it is not enough. No?
Sir.
So
Yes, sir.
it's very important that you should have a slit lamp along with one of those lenses to be able to diagnose the depth and other features that you spoke about. That is the most important thing that you should give to your students, that if you need one device, it is this. It's not even perimetry, it's not even IOP. It is stereoscopic examination of the disc.
Yes, sir.
Shreyash, a small piece of advice. You were very fast in your presentation.
Yes, very fast. Too fast.
It was like more than a Rajdhani, you were just going so fast that
He was
even
too
we
fast
lost
for the
you.
internet.
Even we lost you. See, when you're in these sessions, you cannot be slow, but you cannot be too fast also. Your speed has to be moderate, so much so that you can sort of inform whoever's listening to you about what you want to say. And when you have pictures, like, of course, if you're showing splinter hemorrhages, show it while saying it. Because the thing is that your teaching is that, that this is the notching, this is where it is, this is the loss of nerve fiber layers. You have to show it on the pictures. So the next TOT that you ever go for, remember these points and do it accordingly.
Yes, ma'am.
Stop sharing, Dr. Shreyas. Shall we move to GMC Akola next?
Yes.
Dr. Nikhil.
Harsha and Shivani from which institute?
GMC Nagpur.
Okay.
GMC Nagpur.
GMC Nagpur.
Dr. Nikhil from GMC Akola.
Nikhil Darade.
बहुत फास्ट हो गया
Am I audible to everyone?
Yes, you're audible.
Good afternoon, everyone. Myself, Dr. Nikhil Darade. I will be giving lecture on the topic dyes used in ophthalmology. What are the dyes? Dyes are the various colored compounds which react chemically with the substrate to which they are applied and impart them the color for the better visualization. Do you know what are the various dyes which are used in ophthalmology? Let's see these dyes one by one. Fluorescent dye. It is one of the most commonly used dye in our ophthalm OPD. Dye appears yellow-green under the cobalt blue filter. Dye comes with a ready-to-use strips with which contains 0.6 to 1 milligram of dye per strip. Dye used firmly adheres to the basement membrane and can therefore highlight in the areas of epithelial breakdown. Principle: when dye is stimulated with the light of shorter wavelength, it emits the light of higher wavelengths. Let's see the uses of the dye. It is mostly used to stain the corneal surface for examination of corneal epithelial defects, applanation tonometry, measurement of tear breakup time, Siddle's test, rigid contact lens fitting, and the patency of lacrimal apparatus. Intravenous uses of the dye are fundus fluorescent angiography, iris angiography, vitreous fluorophotometry, and the aqueous fluorophotometry. Let's see the advantages of this dye. This dye comes in a ready-to-use ophthalmic strips, which is non-expensive, easy to use. Disadvantages: sometimes there may be allergic reaction, and dye, though is used for fundus fluorescent angiography, it is not useful for the visualization of choroidal vasculature. Rose Bengal dye. It is another dye which is used in our OPD. It stains mainly the dead and devitalized cells by mainly staining their nucleus. It is used for conjunctival staining, corneal staining, diagnosis of membrane gland dysfunction. Advantages are same as that of fluorescent dye. Disadvantages: dye is more toxic to the ocular surface and can cause higher degree of discomfort to the patient. Lissamine green dye. The mechanism for action of this dye is also same as that of rose Bengal dye. It is used for dry eye diagnosis, proper fitting of contact lenses, and conjunctival staining. Advantages are same as that of rose Bengal and fluorescent dye. It comes with a 1.5 milligram gram dye per strip. Disadvantage: if we use more than 2% concentration, then it might cause a little bit discomfort to the patient. Large quantity of dye might be required. Trypine blue dye. Dye does not penetrate the capsule. As can you see in this image, the dye only staining anterior capsule and not the lens behind it. Concentration which we use for staining the anterior capsule is 0.06%, and posterior segment surgeries we use 0.15%. Advantage of the dye is that there is no waiting time to stain the capsule. It is non-toxic to the corneal endothelium when used in smaller concentrations, and it is safe in the pediatric surgeries also. The problem which arises with the use of this dye is dye gets washed out very quickly, and we cannot use the dye while using hydrophilic acrylic lenses. These are the uses of the dye: stain anterior capsule, peritoneal membrane staining, to stain the descending membrane and the stain the endothelial layer. Junction violet dye is another dye which can be used for staining of anterior capsule, but it causes the endothelial damage, so we don't use this dye. The only use of this dye is to use the intraoperative capsular marking for the toric IOL placements. Triamcinolone dye, as you can see in the video playing besides, the dye is white colored steroid dye. The crystals of the dye binds with the vitreous gel and provides good contrast. Concentration we use of the dye is 4%. Dye is used for vitrectomy or to treat the macular edema. Disadvantages of this dye are it can cause the acceleration of the cataract development in the patient. Indocyanine green dye, it is the gold standard dye used for ILM staining. And mechanism, it has high affinity to the collagen 4 and the laminin. It is better tolerated than the fundus fluorescent. It can cause RP damage if it undergoes. And brilliant blue, it is the best dye to stain internal limiting membrane. Concentration used is 0.025% and 0 to 0.5%. Disadvantage: it can cause atrophic changes if subretinal migration of the dye is seen. Thank you.
Timing okay.
Nikhil,
Yeah.
again, you were also a little fast. You should be a little slower, okay? Don't run over things. Just go stepwise, a little slowly. What is the other use of gentian violet if you have to do some scleral procedures? In what conditions is it used? Something about fixation? You do a secondary IOL fixation, you mark the sclera, no? With
Scleral fixation of secondary IOL.
Yeah. Any other indications?
Even in RD surgery.
Scleral buckling.
Not so much scleral buckling, because we generally use a cautery if we have to mark the area of this. But generally, if you want to do any kind of extraocular surgeries, you can use the gentian violet, stainer, and those are the scleral indications.
I think it was a good presentation because he brought out the points of all the dyes, and he had simultaneously running videos, so one could see where it was being used. I thought you covered all the points very well, Nikhil. Congratulations to that.
Thank you, sir.
If Dr.
Pranali.
Virendra.
Yeah, I think it was a good presentation. Only thing is that at the beginning of the presentation, you should point out why you selected the topic and what is the purpose of this class or whatever teaching module.
Okay, sir.
So that the students, you are supposed to address the students. So what is the importance of this topic to the students? That also should be just pointed out, and maybe you can, the first couple of slides, you should tell the uh, topic which you are going to cover.
Okay, sir.
Yeah.
Dr. Pranali next.
Am I audible, sir?
Yes.
Good afternoon, everyone. Myself, Dr. Pranali Uke, and I'll be talking on the topic of differential diagnosis of the limbal mass. So, what is limbus? Anatomically speaking, limbus refers to circumcorneal transition zone of the conjunctivocorneal and corneoscleral junction. It has pluripotent stem cells and it maintains the corneal epithelium. So, limbal nodule can be categorized based on causes of it as shown below. Moving on to the first cause, which is congenital, it includes dermoid. Dermoid, it is a smooth yellowish soft subconjunctival mass, mostly present infratemporal to the limbus, and it is associated with the golden harrow syndrome and mostly seen in early childhood. Next is a dermolipoma. It mostly present in adult life. It is a soft yellowish subconjunctival mass and may exhibit hair. It mostly located to the outer canthus and occasionally extend towards the limbus. Next is a raised nevus. It is a gray, gelatinous, black-brown, and it may be flat or raised, and it has tendency to grow during puberty or pregnancy. Next is the allergic cause, which includes flectin. It is a small white limbal nodule associated with the intense local hyperemia. It is a delayed hypersensitivity reaction to the staphylococcal antigen or tuberculosis, and it presents with photophobia, lacrimation, blepharospasm, etc. Next is a vernal catarrh. It presents with the multiple nodule in a upper limbus with a white superficial spot with white ropey stinky discharge. It is a hypersensitivity reaction to the exogenous allergens such as pollen dust, mostly seen in the children. Vascular causes includes capillary hemangioma. It is a benign red lesion which blanches on pressure. It may be associated with the hemangioma of the lid and orbit, and it may bleed on trivial trauma. Next one is traumatic cause, which includes granuloma. It forms up mostly after surgical wound, and it is a fibrovascular proliferative response to the conjunctival insult and present few weeks after the surgery. Next is the inclusion cyst. It is a thin wall benign cyst lined with non-keratinizing epithelium containing serous fluid. It is a slowly progressing cyst. Next is a limbal foreign body. Patient present with history of trauma, and it mimics the iris prolapse at limbus. Next is a degenerative cause, which includes cystic pterygium. It is a fibrovascular subepithelial ingrowth of the degenerative bulbar conjunctival tissue over the limbus onto the cornea. It may be malignant. Next is peduncula. It is a yellow-white mold. It is a elastotic degeneration of the conjunctival stroma. It mostly present at the nasal site and seen in elderly. Next is a nutritional cause, which includes bitter spot. It is a silvery white foamy cheesy patch. It is a keratinized epithelium seen temporal to the limbus, mostly seen in vitamin A deficiency. Next is a benign epibarbal tumor, which includes papilloma. It is a benign polypoid tumor. It may be sessile or pedunculated. It associated with the HPV infection of type 6 and or 11, presents juxtalimbally. Next is a reactive pseudoepitheliomatous hyperplasia. It is a rapidly growing juxtalimbal hyperkeratotic nodule secondary to the irritation. Next one is malignant epibulbar tumor, which includes ocular surface squamous cell neoplasia. It presents with the fleshy, gelatinous leukoplakic papillomatous lesion at the limbus. Superficial feeder vessels are prominent here, and it's mostly seen in elderly. Next is a primary melanoma, which presents in a nodular form. It may be pigmented or non-pigmented. Next one is the miscellaneous causes, which include ciliary staphyloma. Ciliary staphyloma presents this bulge in the limbal area. It is lined by root of iris due to ectasia of the weak scar tissue. Next one is the filtering bleb after trabeculectomy surgery. It is a limbal or fornix-based flap of the conjunctiva and Tinon's capsule, which fashioned superiorly. It mostly present with the iridotomy scar. Next is a retention cyst. It is a thin wall cyst with a clear fluid. Excision is indicated if there is irritation or foreign body sensation. So take home message from all this differential diagnosis of the limbal mass is evaluation of the every mass is crucial to rule out malignancy, and regular examination for the intervention is important. Thank you.
Timing over.
Pranali, that was a very nice presentation. You covered all the causes along with pictures, and you were sort of outlining what was there. So that was good in your presentation. Only thing is that where you spoke about the ciliary staphyloma, it has to be more called as an intercalary staphyloma, which is at the this limbus, because ciliary is a little way beyond that.
Behind.
So anyways, a good presentation.
Thank you.
Nagvekar sir.
Yes, I think it was a good presentation. It had all the factors going for her. Maybe you should have only highlighted a little more in case you suspect malignancy. How do you suspect malignancy? Which of these limbal tumors are the ones which you will take special precautions for, and which are the ones you would want to go for referral? You know, if that would be an additional thing, but I think in 4 minutes, it's a lot to ask for.
Virendra sir.
I think the presentation was good. The text content of the slide should be reduced, and you should remember a few things. And the text, the number of words used should be reduced to a minimum. You can just take some
Important words.
They should be just suggest you remind you the topic you are going to cover. You should not write everything down.
Yes. I'll be more cautious. Thanks.
Yeah.
Moving to next candidate, Dr. Pooja from GMC Akola. Disconnected. Start sharing your screen. You have to rush little fast. Next candidates, be ready with your presentation.
There are 4 students from JMC Akola.
Yes, ma'am.
Okay.
Yes, sir. Am I audible?
Yes, start, please.
Yeah.
Okay. Very good afternoon, one and all. I am Dr. Pooja, and I am going to discuss on the topic cause of reduced vision in children, and that affects 2 to 11% of children below 16 years of age. That accounts for 60 to 80% of visual impairment in children. An accurate refraction that will help establishing a normal development of the visual system in children. So, prescribing glasses for children is always a challenge because there is limited cooperation, low reliability in the visual assessment, and the risk of amblyopia is there. So, one must take into account there is strong accommodative elements, age-related emmetropization, and associated conditions like strabismus prior to prescribing the glasses in children. So, let us jump on how to do refraction. First, starting with the visual acuity, again, which has the very, very low reliability. We have age-appropriated charts which are needed to record the vision as per their ages. Let us jump on the retinoscopy, which is pretty much become only way that you can refract the child, and it is the gold standard of the objective refraction.
First of all, the dry retinoscopy. What is it? The retinoscopy, which is done without the cycloplegic drop, is nothing but the dry retinoscopy. It is done to evaluate the ability to accommodate and to see how good are the current glasses. So how does one do it? It is done over the current glasses. Ask the child to look at the distant target and hold a +2 diopter lens in front of the eye. This relaxes the accommodation. Now replace it with +1.5 diopters and do the retinoscopy to see if there is neutrality. As shown in the video, we can see the reflex which is with the movement and becoming more sharper and narrower after adding the plus lenses into it. And once we add the +4.5 appropriate lens into it, it has become the neutralized. Next one is the static retinoscopy. Here, the static refers the patient's relaxed accommodation. The child should fixate at the target, which is at least 6 meters here. We can use the video picture to keep the child's attention. And the common working distance here is 67 centimeter, which gives a working distance lens of 1.5 diopter. Next one is the monocular estimation method, which is nothing but the dynamic retinoscopy, which is done with best correction at the 40 centimeters. In the normally illuminated room, we can do it. As shown in the picture, we can attach an MEM card to the retinoscope and ask the patient to keep reading the letters aloud. While doing that, the examiner needs to quickly neutralize the glow while patient accommodates to fixate a target at near. We have the skyscopy racks also. As shown in the picture, it has the biggest advantage that will allow you to rapidly run through the different parts and can look at the meridians, different meridians. As a child may not allow you to put a trial frame in it. These are not very expensive also. Next one is very, very important, cycloplegic refraction. So why it is important? Because there is a relationship between the accommodation and the ocular coordination, and hence there is a relationship between the refractive state and accommodation. So any patient with the anomalies of the binocular vision and the ocular mortality needs a cycloplegic refraction. So we have some medications here. They are all anticholinergics like cyclopentolate 1%, homatropine 2%, propicamide 0.5%, and the atropine drops or ointment 1%. So here the busy slide showing the different medications with its administration schedule, onset of action, and the duration of cycloplegic action. And we also must take into account that it has some adverse effects. So thank you so much for listening to me.
Pooja,
Time just okay.
your talk should have been designed a little differently. When you talk about refraction in children, you have to talk about refraction in neonates, refraction in pre-verbal children, refraction in verbal children. What you highlighted mostly was the verbal category, where you did the refractions for them, but you have to also show how you do it in younger children. What are the states where you mummify the child, how you do the retinoscopy, how you hold the child, and what are the kind of deletions that you do on the refractive error that you get from the retinoscopy. All that was lacking in your presentation. So the next time, kindly see that all these three aspects are addressed separately. And it's a different ball game of refraction in mentally challenged children, because you have to do it over there, and how you do it also is another ball game. So 3 or 4 categories should be made, and you have to address it, because refraction is a very big topic to address in 4 minutes. I understand that, but you should have just hit upon at least the titles, so we know that you've gone through the entire gamut of refraction in children.
Yes, ma'am. I'll take it into the consideration next time.
Good.
Shall we move to next candidate?
I think it's a good idea to concentrate on a subset of children if you want to present it in 4 minutes.
Yes.
You cannot cover the complete gambit of refraction in children in 4
Impossible,
minutes.
impossible, because it's such a large topic,
Yeah.
So next candidate is Dr. Samiksha. again from GMC Akola. Dr. Pooja, stop sharing your screen so that Samiksha can start.
Good afternoon, everyone.
Stop sharing your.
There is a red button out at the top to stop sharing. Yeah.
Good afternoon. Am I audible?
Yes, you are audible.
Am I audible?
Yes, you are, Samiksha.
You can go ahead.
Good afternoon. Am I audible?
Yes, dear.
Yes, you're audible as well as we can see your presentation. You can go ahead.
Okay. I'm starting now. Good afternoon, everyone. I, Dr. Samiksha, is presenting on the topic newer iOS. My mentor is Dr. Murtaja Hussain, sir. Let's start with the newer iOS, which are monofocal, multifocal, EDOF lenses, and other miscellaneous lenses. Let's start with the monofocal iOS, which, as the name suggests, focus on a single focal point and hence have superior image quality and minimal aberration. The newer monofocals are eye-enhanced, which have great intermediate and distant vision and minimum glare and halo, unlike that of EDOF lenses or the multifocal iOS. The monofocals have great contrast sensitivity. The Envista is the one which has no lens aberration and hence maintains the depth of focus. The third monofocal are the light adjusted ones, which on the UV exposure, the monomers inside the lens, they swell up on the principle of osmosis and hence they change the shape of the lens and change the power of the lens. The next one is the Lux Good preloaded, which has 4 haptic points, which is good for rotational stability and hence they make one of the best toric lenses also. The next are the multifocal iOS, which focus on 2 or more focal points. They are advantageous than monofocal is that after the surgery, the patient might not require glasses for near vision, as in monofocal. And hence these improve the near, intermediate, and distant vision. The recent multifocals are PanOptics and Technic Synergy. The PanOptics has quick neuronal adaptation as these lenses can be instilled in both the eyes. Generally surgeons prefer multifocal in one eye and EDOF lenses in another eye for better vision, but PanOptic can be placed in both the eyes. And it is good for post-LASIK surgery eyes and also for after post-refractive surgery eyes. The Technic Synergy is partly trifocal and partly EDOF, and it has better near vision than the PanOptic one. The disadvantages of multifocal is that it develops capsular opacity and it is increased glare and halo as seen in the picture and hence not good for the nighttime drivers. It has decreased contrast sensitivity and hence not good for readers also. It requires visual cortical neuronal adaptation and it cannot be used in macular pathology like ERM or drusen's. The third ones are the EDOF lenses, which are non-diffractive and hence they have less glare and halo and hence they are superior than the multifocal and the monofocal ones. Although they have poor contrast sensitivity and hence they are poor for reading vision. The three types are small aperture EDOF, EDOF effect lenses, and enhanced monofocal EDOF. The small aperture has a pinhole effect, and as the light passes through a single pinhole, there is less peripheral or less mesopic or nighttime vision. The EDOF effect lens has a spheric anterior surface and posterior diffractive surface. So mixing is possible with these lenses. Like you can put this lens along with the multifocal in another eye. The enhanced monofocal EDOF is just like that of light adjusted monofocal, but here UV rays is not required for changing the geometry and the shape of the lens. Let's come to the accommodating iOS. The newer one is Synchrony Dual Haptic, which has 2 optics, plus anterior and minus posterior, connected by a spring-like haptic. And hence this spring helps in anterior or posterior movement of the lens for accommodation. The Tetraflex accommodating is the recent one, which is under phase 3 FDA trial. And the mechanism of action is similar to that of normal crystalline lens. But the disadvantages is because of the small size, we need a surgical skill to place it, and also it develops early PCO. The toric IOLs are the one which used to correct astigmatism. The newer toric IOLs have are Technis IQ, Envista, and Technis Toric 2. The Envista is better than Technis IQ in that it is faster unfolding and has better rotational stability. But the Technis IQ corrects up to 3 to 4 diopter of cylindrical power, but Envista corrects less than 1 diopter of cylindrical power. The Technis Toric 2 is the most recent one, which has square edge. Hence, there is decreased PCO formation and it has great rotational stability as seen in the diagram. Let's come to the phakic lens. The implantable columnar lens is the newest one with a central hole or vault, which helps in free movement of the aqueous, and hence PI, YAG PI is not necessary as in the previous ICL lenses. These are used for myopes of -3 to -20 diopter of sphere in younger age groups, 21 to 45 years group. And the phakic IOLs are placed in front of normal crystalline lens without removing it. And hence the complications will be iris or lens related, like endothelial cell damage, pigment dispersion, inflammation, or cataract development in the normal crystalline lens. The aspheric IOLs have a prolet surface, and hence they have better contrast sensitivity, better mesopic vision, nighttime driving, and better for younger patients. The disadvantage is that they have decreased depth perception and they are more expensive. The most recent ones are the telescopic IOLs, which contain number of micro lenses which magnify objects in the central visual field. These are placed in the posterior chamber and they are helpful in patients with ARMD or the macular pathology. But as the light focuses on macula or also on the periphery, there is decreased peripheral vision and there is difficulty in the future laser treatment if the patient requires. Also, because of its structure, it is surgically more challenging to insert it and it causes endothelial compromise. Thank you.
Time 5:30.
Time was okay?
No, beyond
5:30, 1.5 minute extra.
Okay. Is Dr. Virendra to say something? I will join him later on.
Yeah, I wanted to say that they should be given a warning signal 1 minute before the completion of time.
Okay, Samiksha, there were many things which I would like to point out. Number one, when you spoke about toric lenses, you spoke about, the Technis 2 being the most advanced lens. But you forgot that there are other lenses also currently available in the market which achieve the same thing as Technis 2. Light adjustable IOLs are not yet available in the market. They are still under investigational review. Do you know what is the greatest disadvantage of a light adjustable lens? Do you know what the post-op thing is for these patients?
So they require protection from the UV light for at least 3 weeks after implantation.
Yes, exactly. So they have to be mainly indoors for that much period of time. Okay. And how is the light adjusted? How is the IOL power adjusted?
Sir, the macromolecules inside the lens on UV exposure
How is the power adjusted afterwards? After 3 weeks or whatever?
So patient is allowed to go in the UV exposure.
No, patient has to sit in front of a special slit lamp and adjustment is done. So these are not things which I think you should tell your students right now. Okay. Then there's another controversial point you brought about that trifocals are good for patients with previous keratorefractive surgery. It is quite the opposite actually, ma'am. Because basically when you're doing any keratorefractive surgery, the corneal shape is made highly oblate. And these people have high spherical aberration. The spherical aberration goes to 1.5, 1.6 and all that. So when you're using these kind of lenses, the amount of glare is much more. The much more forgiving lens in cases of post-refractive surgery, besides a monofocal lens, is actually an extended depth of focus lens, and not a trifocal lens. I mean, there are many more points in the lecture I will go around, which were quite controversial if you ask me, So I think you should research well before you present and make sure that you've got all the points of view. Basically, just don't copy from Google or whatever as what is latest available. Also go into reviews of these products and what they have been doing, or ask experts who implant these lenses. They will be able to teach you better, as to what has to be done.
Okay, sir.
I want to know the difference between enhanced monofocal and EDOF lens.
So the enhanced monofocal is a type of EDOF lenses, but in enhanced monofocal, the lens can change its shape and geometry.
No. See, enhanced monofocal gives you a depth of only 0.5 diopters. Whereas if you go and look at the real extended depth of focus lenses, which are not based on a multifocal principle, I'm talking in terms of lenses like maybe the Vivity, they give you a depth of focus of about 1.5 diopters. So it's a totally different category. Well, one is an advanced monofocal, one is a true EDOF. And EDOFs are like this, the ones which are multifocal, like for example, the Symphony earlier, which has been incorporated in the Synergy, or those which are true EDOFs, where you have a curvature shape, like you see in the Vivity, or you see in the Lucidis. So those are different lenses. So there's a different category over there.
Okay, I think we can move on.
Okay, thank you.
So coming to the last college, VNGMC Yavatmal, Dr. Pranali. Start sharing the screen. Start sharing the screen, green button.
Good afternoon, sir. Good afternoon, everyone. My today's topic is biometry. Am I audible, sir?
Yes.
Yeah, we can hear.
My today's topic is biometry. Biometry is the physical measurement of ocular dimensions, which are used as a input variables in the formula of IL power calculation.
I think you can go to slideshow. Yeah, right. Go ahead.
Previously, the goals of cataract surgery were just for the good visual outcome. They were doing the cataract surgery. But nowadays, the goal of cataract surgery is good refractive outcome. For good refractive outcome, we are targeting emmetropia and cataract surgery. For that, we use four things. We perform a good safe surgery, then address the astigmatism, use a premium IOL, and increase the refractive accuracy by calculating the IL power. The first IL implanted by the Sir Harold Ridley in 1949, which is made up of PMMA. Okay, for the biometry, the useful things are measurement of axial length and the keratometry. For measurement of axial length, the two techniques are there. One is contact A-scan measurement, and second is immersion A-scan measurement. For contact A-scan measurement, we use the probe, which is placed on corneal center of the cornea, and we calculate the axial length. Then in immersion A-scan, we use some shell, and in that shell there is some fluid is there, and we then we calculate the axial length. By using immersion biometry, we minimize the corneal contact, and hence we increase the preciseness of axial length measurement.
Are your slides
For
moving?
axial length,
Oh.
no, sir. Okay. These are the two photos. First is contact scan and second is immersion biometry. The spikes which we get in contact is immersion biometry is one more than than what we get in contact scan. Because of that one peak is because of the probing of fluid onto the probe. Then second thing is we do is keratometry. We do measurement of corneal curvature with the help of either manual keratometry or autorefractive keratometer or other or other automated keratometers. Or also we can use the IL master or lens star. For keratometry, the preciseness of keratometry is 1:1 ratio. If we make a false estimation of keratometry, then
Your slides are not moving.
in keratometry.
Okay. You can carry on.
Sir, I'm done.
Don't worry, you can go ahead. You can finish your job. Nothing to worry about. Just you can go ahead.
Sir, in keratometry, if there is a measure in keratometry, 1 mm of.
Is your time up?
Yes.
Yes.
Okay, you can stop then. I think it's a good thing that you have attempted to do something and don't get disheartened by this.
Pooja, no? Your name is? No, Pranali. Pranali, could you tell us how you would calculate the refractive power in children where you want to implant an IOL?
Ma'am, we can use intraoperative aberrometry techniques, or we can go with the optical biometry techniques, in which we directly measure the axial length and keratometry readings at the same sitting.
Yes, but then when you have to decide what power you will give the children, would be age dependent, or how you would calculate it? Because it's not the complete thing how we do it in adults, no? So how would you manage that?
Will you overcorrect or undercorrect the children?
Undercorrect.
Okay.
See, you go according to the Halliday's rule and you give 80% up to 2 years of age, 1 or 2 years of age, and beyond that you give 90%. So that's how you calculate and you give the according. And you have to tell the parents also that you will give a refractive glasses over and above the contact lens, I mean the intraocular lens put in till the person comes of age.
What is the difference between IL Master 500 and IL Master 700 in technology?
And which is more accurate.
It's all right. We can go ahead. We can move to the next candidate.
The last presentation of the day, Dr. Shubhangi from GMC Vatmar. You can start sharing the screen.
Yes.
Good afternoon, everyone. My name is Dr. Shubhangi Adkari. My guide name is Dr. Sudhir Penke. My today's topic is treatment of a neovascular glaucoma. Neovascular glaucoma is a severe form of secondary glaucoma, which is characterized by the proliferation of fibrovascular tissue in angle of anterior chamber.
Slides are not moving.
I'm trying. So treatment of a neovascular glaucoma has a three main principles. It includes the treatment of a retinal ischemia, treatment of a raised intraocular pressure, and treatment of a ocular inflammation. In treatment of a retinal ischemia, we have a three different modalities: pan-retinal photocoagulation, intravitreal anti-VEGF injections, and anterior retinal cryopexy. Pan-retinal photocoagulation is the current treatment of a choice wherever there is a retinal ischemia is a cause of a neovascular glaucoma. It involves the 1200 to 1600 burns of approximately 500 micrometer spot size. Ideally, pan-retinal photocoagulation should be completed in 1 to 3 sessions over a period of time of 5 to 7 days. Place the laser spot in a peripheral retina for 360 degrees, sparing the central 30 degree of retina in pan-retinal photocoagulation. Next is intravitreal anti-VEGFs. It includes the bevacizumab, ranibizumab. Bevacizumab we can give at a dose of 1.25 milligram per 0.05 ml. It inhibits the vascular endothelial growth factor and receptor interaction and block the angiogenesis and vascular permeability. Intravitreal anti-bevacizumab intravitreal bevacizumab should always be used irrespective of the clarity of media, and it should be given as a multiple injections because it has a short lifespan. It helps in clearing of the media, so that we should plan for further pan-retinal photocoagulation. Next is anterior retinal cryopexy. It is indicated if the IOP is still high despite of maximal pan-retinal photocoagulation, media is hazy, so that we are unable to do pan-retinal photocoagulation, painful blind eye, and if we needed the IOP reduction at a faster level. For the treatment of neovascular glaucoma, combination therapy has a higher success rate than the single treatment modalities. Hence, we can use the pan-retinal photocoagulation along with the intravitreal bevacizumab and cryopexy rather than giving the pan-retinal photocoagulation alone. Next treatment modality is to reduce the intraocular pressure. We can manage the intraocular pressure medically and surgically. We use the anti-glaucoma medication drugs, which decreases the aqueous production. It includes the carbonic anhydrase inhibitor, beta blocker, alpha-2 agonist. We avoid the prostaglandin analogs because they increases the ocular inflammation. Surgical management include the trabeculectomy, glaucoma drainage device, and cyclophotocoagulation. Trabeculectomy with the use of antimetabolites such as mitomycin C and 5-fluorouracil has a higher success rate. But the most common complication of trabeculectomy is the hyphema in a neovascular glaucoma. So as to reduce that, we can give preoperatively intravitreal bevacizumab. We can do peripheral cauterization of iris and avoiding hypotony. Next is glaucoma drainage devices. It includes the walled and non-walled implants. But in eyes with a non-vascular glaucoma, walled implants are preferred to help with immediate IOP reduction with a lesser possibilities of hypotony. Glaucoma drainage devices are considered as a primary surgical procedure, especially when there is any high risk for failure of filtering surgery. Next is cycloablation. Cycloablation is preferred in a refractive neovascular glaucoma with no PLI to relieve the ocular pain. It includes the cyclocryotherapy, transscleral cyclophotocoagulation, and endoscopic cyclophotocoagulation. Last treatment modalities is treatment of ocular inflammation by giving the topical steroids and cyclophages. So this is the management protocol for treatment of neovascular glaucoma. It based on the initial factor is intraocular pressure, whether the pressure is high or normal. In case of a high intraocular pressure,
Are you finished?
Can I continue?
Yes, you can go ahead.
In case of a intraocular pressure is high, but vision is no PL and no pain, we can only observe the patient. And if the patient has a painful blind eye, we can go for the topical cycloplegic and steroid. If even after giving the topical drugs, if there is a persistence of the pain, we can go for further evisceration and cyclodestructive procedures. In case of a high PL, but patient has a better vision and PL and media is clear, we will proceed for the three main principles of the treatment of neovascular glaucoma. Controlling of the IOP with the medical therapy and surgical therapy, treatment of the etiology. It includes the intravitreal bevacizumab in all the cases plus pan-retinal photocoagulation in 2 to 3 settings within 1 week. Follow-up of the patients after the 1 week, and treatment of the inflammation by topical steroids and cycloplegic. If the media is not clear because of presence of
You have
corneal
only
edema,
30
we can,
seconds. 30 seconds you should finish.
in presence of corneal edema, we can give the medical control of intraocular pressure along with the intravitreal bevacizumab and anterior retinal cryopexy. If the media gets clear, we can proceed for the pan-retinal photocoagulation, and if the media still doesn't get clear, we can proceed for the glaucoma filtration surgery.
Shubhangi,
Yes.
that was good. Only I wish you had kept a little to time, because the thing is that you have to bring it all within those 4 minutes. That's the whole scene. You have not mentioned something about the cyclodiode. Which form of treatment you would use for neovascular glaucoma?
Ma'am, I will choose pan-retinal photocoagulation along with intravitreal bevacizumab plus control with medical therapy to control the intraocular pressure and topical steroids and cycloplegic.
You would use topical steroids very easily because this is a patient of glaucoma, though of course it's neovascular glaucoma. And if you have a blind eye or a eye with a less vision, with a high IOP of 50, would you consider doing diathermy? I mean, endocyclodiathermy?
First, we try to that.
See, you can do you can use the diode laser probe to ablate the ciliary instead of the cryopexy, because the cryopexy causes a lot of swelling, and in the first few days the pressures go up a little bit. So if there's a pressure of 50 causing pain to the patient, it would really go up. It starts subsiding after the 3rd day. So a cyclodiode, where you give it in 2 quadrants, that is first 180 or the lower 180, is in 2 sessions. That is a preferred method because the amount of pressurize is really not so much in that. And suppose you have a patient who's got a bleed inside from the neovascular processes, then you can combine a pars plana vitrectomy along with a PRP, as well as you can do an endo ablation of the ciliary processes. So you have to know these are things also which you should have highlighted in your talk. Huh?
So I thought, she also had a lot of repetition. You could have condensed if you had shown this outline as your first slide and then spoke about a few things, then you have given a general idea to your students, what you'll do in a blind eye and what you'll do in a seeing eye. And then you could highlight more. You could speak about aqueous drainage devices. You could have spoken about the Ahmed valve, for instance. So, which is a common procedure. I think you have to tell the students that. And you have to start with treatment simultaneously. Just don't inject intravitreally. You have to give the patient oral acetazolamide. You have to give the patient topical treatment, including steroids and hypotensive agents, as well as do this. So give them a flow chart as to what you'll do when the patient presents to you for the first time. Because there are many things to be done. This gives them impression you'll first inject anti-VEGF, then after that you treat that. No, things move simultaneously. What moves later on are the definitive procedures, like what Karobi spoke about. But
Yes.
overall, I think you covered everything. Yeah, fine.
It was a big topic, vast topic,
Vast
which was
topic.
difficult to be covered. Yeah. And instead of that, you could have selected a topic like role of glaucoma valves in the treatment of neovascular glaucoma, something like that. That could have reduced the scope of the talk. Okay.
So here we come to end of this session with the last presentation. And before I conclude today, I would really like to thank all the participants for all their efforts made during their busy residency schedules. I know most of them are JR 1 and 2, and it's very difficult to take out time, especially when you have an epidemic of conjunctivitis and all, you are flooded with works in medical colleges. So, and taking out time on the 15th August, which was supposed to be a holiday for them. So, and I cannot end the concluding talk without thanking a lot to our esteemed judges who could spare so much of time on this holiday and almost afternoon spent over this judging session. So I would really like to thank Dr. Karobi Lahari ma'am, Dr. Sandeep Nagvekar sir, and Dr. Virendra
Thank you.